Hello. I'd like to welcome you now to the continuation of our pathology teaching. As you know, that we teach pathology in steps. You've already gone through the first 3-4 steps, like the TBL session on beginning of the week, and then you've received the learning objectives for this week related to colorectal cancer on Sunday, and you've responded with your reports the next day. And we just completed the IRAD-GRAD, which is related to readiness assurance test questions. And now we'll continue with our TBL resource session pre-lab to proceed tomorrow with your practical. Let's go over a few points we're going to discuss during this session. Colorectal cancer, or tumors of the intestine, we will classify them into non-neoplastic polyps and neoplastic lesions or epithelial lesions, and there will be others like GIST, carcinoid, and mold related to H. pylori infection, as you know already. Let's take a look at a full colectomy specimen here. If you see this colon, this has been removed totally for a purpose, because you see this is abnormal compared to normal. Can you tell what's the abnormality here? Anyone would like to? Yes, please, go ahead.
There are multiple polyps.
Okay, excellent. We have really, actually, the whole colon is studded with hundreds of polyps. Some of them are small and others are large. Let's go over a story. How would this develop, or how we proceed to colectomy? Why don't you read the story and let's see what it says.
A 19-year-old man is advised to see his physician because genetic screening has detected the disease in other family members. Stool sample is positive for occult blood. Colonoscopy is performed, followed by a colectomy. The colon shows hundreds of polyps. Molecular analysis of the patient's normal fibroblast is most likely to show a mutation in which gene?
So you kind of interpret now or deduct that there is a genetic problem, and there is a gene which has been mutated, which led to formation of these polyps. And you can tell here, I hope you understand all of these words in the story. Like occult blood, it means that presence of blood which you don't see by naked eye, but you can detect it chemically. And colectomy means colonoscopy first, that you do a procedure to look into inside the colon. And we've seen so many polyps here, and that's why colectomy was performed in such a background of this genetic story in this family. Although he is young, but we've done the colectomy to avoid further development of more than polyps. And we will see in a moment what is really the background of formation of these polyps. And here you can see that there is a concept called adenoma carcinoma sequence. That means adenoma, benign tumor, can proceed into carcinoma after accumulation of genetic changes we call mutations, and you're familiar with what we mean by mutation. And actually what you have a normal mucosa here, becomes a mucosa at risk. That means may develop tumor or neoplasm, and that's because of what we call a first hit, hitting the one allele of the APC, adenosis polyposis coli, on chromosome 5q. And then there will be a second hit attacking the other allele of the same gene, and then leading to actually not being mucosa at risk anymore, but maybe development of adenoma. The adenoma could be sessile, that means without a stalk, or pedunculated with a stalk. You can see a stalk here. And then eventually with accumulation of other mutations in other genes that can encourage or actually deviate or change the cell genetic material into becoming an invasive cell and becomes a carcinoma. And this is what we call adenoma carcinoma sequence, and that's probably what has happened or what can happen in this case which I've shown you, and that's why colectomy was done, to prevent further formation of cancer in this young man because of the strong family history. Here is just summarizing all the steps I talked about of the APC gene, first hit, second hit, and then mutation in the KRAS, and then eventually there's also additional mutations or loss of heterozygosity to inactivate tumor suppressor gene P53 on chromosome 17 and SMAD2 and SMAD4. Eventually, accumulation of all of these mutations, not necessarily in any order, can lead to formation of cancer. So order is not important. More important is accumulation of these mutations which can lead to cancer formation. This is one way of pushing towards adenoma carcinoma sequence, but in case there is no adenoma in the beginning, but you get a de novo, or actually non-familial or non-inherited also genetic changes, which can lead to what we call microsatellite instability or DNA mismatch repair pathway. Also, again here, accumulation of mutations can lead to formation of what we call sessile polyp here, mainly adenoma, but could be villous adenoma. I'll show you a case of that, and then eventually can lead to carcinoma after accumulation of mutation. Again, here is just a summary of what I have said to you. This is a case showing some polyps here. You can see that. And this is a story which I would like you to probably get acquainted with. Anyone would like to read? Please go ahead, Abdullah.
66-year-old man had a positive stool sample for occult blood. Colonoscopy showed 5 centimeters sessile mass in the upper portion of the descending colon. The histologic appearance of the lesion was that of a villous adenoma. The patient refuses further treatment. 5 years later, he comes to the clinic because of constipation, microcytic anemia, and 5 kilograms weight loss over the past 6 months. On surgical exploration, there is a 7 centimeter mass encircling the descending colon. Which of the following neoplasms is he now most likely to have? Villous adenoma, lymphoma, carcinoid tumor, leiomyosarcoma, adenocarcinoma.
Okay, here you can tell that there is a previous story of villous adenoma, which you can see here, showing you a sessile adenoma with feathery-looking appearance and abnormal nuclei, which you can't see at this magnification. But this is how villous adenoma looks like. But the patient refused to take any treatment. The treatment for this adenoma or sessile adenoma, sessile polyp, should be a partial resection of the colon, not removing the polyp only, because it's sessile, it's difficult to remove, and again, because of this type of adenoma, villous adenoma, it requires resection with safe margins. But the patient refused to undertake this procedure, so 5 years later, he came back with problem with constipation, because the location of the neoplasm is on which side of the colon? The descending or the left side, and that leads to constrictive feature. Usually it involves the whole circumference of the colon and can block and lead to obstruction, and that's why the patient had constipation, and then because of the hemorrhage from the ulceration had anemia, and then weight loss also over a period of time, and we've seen this ulcerating circumferential tumor, and this has really developed because the previous lesion was not removed on time. So what do you expect the answer to be? Is it the villous adenoma continuing and proceeding to be like this?
No.
Actually, no, it's more than the villous adenoma. It's okay, I have one. Is it lymphoma? Has been converted to lymphoma? No, it's not. Carcinoid tumor, we'll talk about that later. Leiomyosarcoma, no, it's more likely to be an adenocarcinoma, which has evolved from villous adenoma and led to this ulceration and these clinical features here. So you can see here that polyps of the colon in general can be adenoma, but could be hyperplastic polyp, which is non-neoplastic. Hyperplastic is usually non-neoplastic. And it could be sessile, like this here, located on the surface of the mucosa, like this one here, also the villous adenoma, which is sessile, or could be pedunculated with a stalk here. Okay, if we remove the polyp, especially in tubular adenoma, we have to check the margin of the stalk to make sure it's not involved by the adenoma. Here is a picture showing you normal gland here in the colon. Compare this normal gland with these glands here. One of them is here, another one here, another one here. What do you see? What's the difference between this normal and this, I would call it abnormal gland, or I call it hyperplastic polyp, or this piece is removed from a hyperplastic polyp. What do you think the difference here between the two? Anyone can describe what, compare them and say, what do you think? Who would like to respond, please? Another person, another student, please. Yes, please, Abdullah.
Looks more crowded.
Okay.
And they're deeper glands.
Okay, so actually what you're trying to say is that you have something coming into the lumen, right? So more cells, hyperplasia, hyperplastic polyp, more cells coming into the lumen, and actually we call them fronds, some fronds going in. So this is hyperplastic polyp. It's not neoplastic, it's hyperplasia. It's not neoplasia. So it doesn't predispose to cancer in the future, unlike the villus adenoma, which we've seen earlier. This is another tumor, or another polyp actually. It's not a tumor, it's a hamartoma. It's seen usually in a case called Butt-Yeager syndrome. You're familiar with Butt-Yeager syndrome? This can develop this type of polyps, which contain within the hyperplastic glands or cells, or columnar cells. We have also smooth muscle cells in there. Okay, so these are the two types of polyps which do not predispose to cancer. Here is another polyp with a stalk. Here is the stalk, and this is the polyp. This is an adenoma or tubular adenoma, which is pedunculated and can develop cancer, but in a small percentage of cases, as I will show you in a moment. But the villus adenoma here, the feathery look into the arrangement of these glands, carry a higher risk of cancer, as you know. This is a sessile adenomatous epithelium, similar to this one, but it's not pedunculated. It's just a small area. Compared to normal, you can see there is darkness here. Nuclei are being large and darker by staining, so hyperchromatic. And that's how you can tell the difference between normal on this side and abnormal on this side. In relation to the villus adenoma, you can see the abnormality here. Again, darker nuclei, larger nuclei compared to the normal other side to your right over there. Okay, so let's classify these polyps. Intestinal polyp can be classified, as I mentioned earlier, into neoplastic and non-neoplastic. Most important neoplastic is tubular adenoma and villus adenoma. These two are most important. Tubular adenoma, probably you can see it in 90% of the polyps in the colon. When we screen by colonoscopy, we see a lot of them, a lot of tubular adenoma. Usually the size is less than 1 centimeter, and the cancer risk is about 1 to 3%. While villus adenomas, the feathery look to it, you've seen that, makes about 10% of the polyps in general, the other 10%. So 90% tubular, 10% villus, and usually the size is more than 1 to 5 centimeter, and the cancer risk is 50%. You've seen a case, I've shown you a case that villus adenoma had transformed into adenocarcinoma, and that's because of 50% risk of development. So 1 in 2 patients may develop cancer if they harbor villus adenoma. That's why it's advised to remove the villus adenoma, but not by polypectomy, because polypectomy is not enough. You need to do a resection with safety margins of the colon. There are other polyps which can develop, like carcinoid. We'll talk about that later in the session. Leiomyoma, lipoma, all of these can also show polyps. So these do not usually carry risk of cancer. Carcinoid is a low-grade cancer by itself anyway. Non-neoplastic polyps include hyperplastic polyps, as I've shown you earlier, and hamartomas, which I've shown you a case of Butt-Yeager syndrome, juvenile retention polyp, lymphoid polyp, inflammatory polyp. So there are so many types of polyps, but usually these do not carry major risk to cancer like the tubular adenoma and the villus adenoma per se. Villus adenoma means 50% cancer risk. Predisposing factors, then let's summarize what we have talked about and add more information. We have predisposing factors like family history of cancer, colorectal cancer. will make about 15% of colorectal cancers in general in the population. Specific genetic syndromes will make 6%, including the hereditary non-polyposis colorectal cancer, 5%, FAP, familial adenosis polyps, the case I've shown you, 1%, Buziaker syndrome, juvenile polyposis, usually negligible risk. But inflammatory bowel disease like ulcerative colitis, more than Crohn's disease, will carry a risk which is less than 1%. You can accumulate this in about 20% of the colon cancer, but actually about 80% are sporadic, not related to these genetic predisposition. And what really make the sporadic colorectal cancer occur, there are risk factors, including older age, history of adenomatous polyp, as I've shown you earlier, increased calorie diet or intake, fat intake, barbecued meat, also it has some carcinogens thought to be effective in producing or in enhancing the vulnerability to colorectal cancer, obesity, smoking, alcohol, and there is an addition by a study done in Melbourne, Australia. They found that excessive stress or major stress as by itself as a factor, a single factor, and it is isolated factor than the others, also carry a high risk of development of colorectal cancer. And this is according to the study done in Melbourne. But what gives you a protective fact or a protective measure against colorectal cancer? Maybe fiber diet and exercise, they say, can probably give you some protective measure here. As we mentioned earlier, colorectal cancer can occur in any place in the colon. And there is a difference in presentation, clinical presentation, between the right side of the colon and left side of the colon. Mainly the right side, usually the presentation is fatigue. And the reason for that this tumor can grow to a large extent with fungating, then ulcerating, and oozing blood that leads to fatigue. Actually, the presentation is fatigue, not something related to the bowel. So whenever you have a patient complaining of, let's say, anorexia, fatigue, anemia, you have to think, put in your mind that, keep in your mind that you should think of ruling out colon cancer, especially the right side colon cancer. So this is important to keep in mind. While if it's on the left side, it's usually alteration in bowel habits, and that's because of the constrictive manner of this tumor here. It usually constricts the colon, as I mentioned earlier, and causes blockage above, and will lead to constipation, and then later on, because of fermentation of the bacteria above the constriction, that lead to diarrhea, and then will lead eventually to, as it's mentioned, the alteration of bowel habit, constipation, diarrhea, so on and so forth. So this is the main presenting sign as compared to the right side colon. So this side, left-sided colon cancer present with alternating bowel habit. Or may also give you colicky abdominal pain, anemia because of the ulceration and bleeding, weight loss for sure, like any cancer, both of them can give you weight loss, and abdominal distension and discomfort because of the blockage, and may give you also red blood bleeding per rectum. Colon cancer, as I said, can involve any part of the colon. The right side would be about 35% of the cases, transverse colon 10%, and the left side usually about 35 like this, but there are 15% is in the lower right colon in the sigmoid portion of the colon. So the total on the left side would be about 55% of the colon cancer is seen. So majority of colon cancer is seen on which side? Left side. And all of them, wherever it is, the colon cancer, be it on the right, in the transverse, or in the left side descending colon, all of them will show the same picture. This is normal gland, as I've told you in the histology, but this is abnormal. This is adenocarcinoma. This is the adenocarcinoma, what you see in either in both places or anywhere in the colon. We'll give you adenocarcinoma picture. This adenocarcinoma can be well differentiated, moderately differentiated, or poorly differentiated. We'll talk about that in a moment. You can see here normal longitudinal section of normal glands, and these are the crypts, and this is the cross section, and here is the abnormal adenocarcinoma, but you can still tell there are glands. So this will be called well differentiated. It's not fully differentiated yet. And here I would like to mention to you that colon cancer produces CEA, carcinoembryonic antigen. Okay, and this is what we call a glycoprotein secreted by fetal intestinal cells, but also is secreted by adenocarcinoma cells. Usually seen in about 60 to 80% of colon cancer producing CEA. So you can check CEA in the serum and in the tissues of the cancer. But CEA is also produced by other carcinomas like pancreatic carcinoma, gallbladder, and lung. Also can be secreted by regenerating mucosal cells of inflammatory bowel disease, ulcerative colitis, Crohn's disease. It can be also seen with a high serum level in alcoholic cirrhosis and in smoking. So all of these really should be taken into consideration. CEA is not a good marker for diagnosis. It is usually a good marker for follow-up, because it is increased in adenocarcinoma of the colon, colorectal cancer, but after removing, the CEA will go down. You check the CEA later on with follow-up. If it goes up, then you think of recurrence. Very good. So in addition to knowing that it is adenocarcinoma, diagnosing the case as adenocarcinoma, we need to know what is the grade. And usually it could be either grade 1, 2, or 3. 1, well differentiated, 2, moderately differentiated, 3, poorly differentiated. And you can see here, this looks like well differentiated. This is more like poorly differentiated. If we take this corner here, look, it has anaplasia. So anaplasia is the key word here in grading cancer generally. So this is well differentiated, moderately differentiated. Here we don't see any glands, so we expect it to be high grade, which is poorly differentiated cancer. In addition, we need to evaluate the margins. When we take a colon cancer, we take safety margins. As you see, the tumor is located here in the cecum, but we still take portion of the ileum and a large portion of the ascending colon. So we have to check this margin and this margin to make sure there is no cancer there, so we remove the whole tumor out, in addition to checking lymph nodes and if there are other metastases, as I will show you in a moment. So this is diagnosing adenocarcinoma, grading it, checking the margins, and now we have to do staging. Staging of colorectal cancer is based on at least 2 methodology, or 2 systems that have been followed. Duke system, which is the older one, which is liked by the surgeons, so it's loved by the surgeons, they like Duke. And Duke is divided into A, B, C, the original Duke, A, B, C, based on the extent of invasion of the tumor through the wall of the colon. I'll show you that in a moment. But this has been improved and developed, as I will show you in a moment. Also, there is another system called TNM, and you're familiar with TNM already before. Let's go over these 2 systems here. What we mean by staging cancer. It's not only looking at the cancer and how far it's gone in the wall, but whether it has gone to lymph nodes, regional lymph nodes or other lymph nodes, or whether it has metastasized to other organs like the liver here. It has gone here to the liver. You can see multiple nodules here indicating that there are metastases, and the primary is here in the cecum. Duke system has been developed by Estler-Kohler of Duke staging into, instead of A, B, and C, now it is A, B1, B2, C1, C2, and D added. A, involvement of the mucosa and submucosa, like here in this case, and here survival after resection, usually close to 100%. So it's curable when it is at this stage A. When it is B, that means it's gone into the muscularis here, then you can see the survival drops down 1/3. It becomes 67. If it goes through the muscularis but no lymph node involvement, then it becomes about 55. When there is lymph node, down to 40. Beyond the muscularis into the serosa here, it becomes 20. If we have distant metastasis, as we have seen in the liver earlier, then really the survival rate drops way down below 10%. According to TNM, also you get similar figures here, but TNM here is more delineated, more details here, like TIS, meaning carcinoma in situ, limited to the mucosa. T1 invades the submucosa, T2 in the muscularis propria, T3 penetrating into the subserosa, and then T4 invades other organ outside the colon, okay, neighboring organ. NX means that we cannot assess the lymph node involvement, N0 that we assessed but no metastases, N1 metastasis to about 3 lymph nodes, not more than 3, 1 to 3. If it goes beyond 3, that means 4 and more, then it becomes N2. Now M, if we can't assess metastases to other organs, we call it MX. If we assess by CT scan, MRI, you know the difference between grading and staging, right? Grading is grading the tumor itself, histologically speaking, under the microscope. While staging, we have to do the whole body. That means if you say M0, no distant metastasis, that means you have done CT scan and MRI of the whole body, like abdomen, lungs, to make sure, and brain, to make sure there are no metastases. Then we can say M0. But if we find any metastasis in the liver or in the lungs or in the brain or in the bone, then we call it M1. And you can see how the 5-year survival rate drops from almost 100% here or 97% all the way down to 4% when there are metastases here. Treatment, how do we treat? The standard of treatment is surgery. It has to be removed. But at times, when there are metastases to lymph nodes, you have to dissect the lymph nodes. And even when there are no metastases to lymph nodes, we have to remove the lymph nodes to check whether there are microscopic foci of metastases into lymph nodes. And we have to check also, as I said, by CT scan, MRI, metastases to other organs. So we may use chemotherapy also to treat metastases, or radiotherapy, or combination of all of these three modalities. Now we have discussed the non-neoplastic polyps, the neoplastic epithelial lesions, and there are others. Now, as I said, the gastrointestinal stromal tumors, it could be benign or malignant. Carcinoid, this is a picture of carcinoid, but usually not affecting the large bowel. It can be seen in the large bowel, but usually in the small bowel, like in this case here. And you can see monotonous proliferation of these cells with salt and pepper, appearance of the chromatin in nuclei, and in the cytoplasm you can see neurosecretory granules by electron microscopy, indicating this is a carcinoid. Lipoma can occur, neuroma, angioma, Kaposi sarcoma, lymphoma, mainly the one which is related to the infection by H. pylori organism, which can lead to what we call moltoma or mucosa-associated lymphoid tissue lesion. These are the references which you are aware of. You had them along with the learning objectives. I have sent them to you. And now be prepared for tomorrow's practical session. Review this lecture and try to be ready to make your report for the practical session, and on Thursday for your TBL revision of the whole week. If any questions, I would be happy to answer.
Thank you.
You're welcome.